grab one of their friends, grab one of their coaches, get a teammate to help you do some of these things. You don't necessarily need to be the best athlete to do all those. So really hone in on those reports of dizziness. They just feel they have problems focusing. They have this unstable vision. They're in busy environments. They're getting symptoms increase. They just feel like they're off balance. These are some of the individuals that you want to go ahead and look and do that VOMS with. Conversation is key. A lot of things I learn about my patients is just through conversation. Yes, I still utilize the tools that we talked about. I do the symptom checklist with them, and I go through the SCAP form with them, and I do all those things. But then I also just ask them some questions, like how's class going? How's walking between classes? Have you been going out with your buddies at night? What are the things they're doing in their everyday life? Because I want to really capture them as a whole. Right? They're an athlete, but they're only an athlete for a portion of their day. So if all we worry about is, oh, can I get you back onto the field, we're only doing a small part of our job. I have to get them back into the classroom, but also, too, I have to get them back into their social life. I have to get them back into everything else that is their normal, and so I need to ask questions about that, and and some of our tools just does encapsulate all that. So I also talk about examine different environments. I had a soccer player who we were doing really great on his return to play. We were doing great with his vestibular rehab, but we kind of hit this plateau where every day after so he was a college athlete, he had sociology 3 days a week, and every time he came back from having sociology, he was symptomatic. And he enjoyed sociology, so he wasn't trying to get out of class. And I said, well, where do you sit? Can you describe your classroom and tell me where you sit? And so we did, and then I emailed his professor, and I said, hey, would there be a time I could come by and see with this athlete where he sits in class and just get an idea? And what we recognized was his seat in class, he had to do a lot of up and down head movement. So that amount of head movement was triggering his symptoms. We switched his seat in class, and we started to really push forward in his rehab. So don't be afraid if you have the opportunity to go to the classroom to do that. If you don't, I understand not every environment has that ability. Ask those questions, try to figure some of those things out. Access all complaints. So keep expanding your toolbox. Hopefully here today you saw a couple of different tools that maybe you haven't been using and that you can potentially use in your patients. So I just encourage you to keep expanding your toolbox. A lot of these things are available for free online. So really when we look at impact of some of the budgets and that, it's really small. And sometimes some of these evaluation tools, so your patient-reported outcomes, sometimes you could do them electronically, so then there wouldn't even be any paper involvement. So just things to really think about as you go forward. You guys are doing awesome things, so I really want you guys to continue being awesome and doing great things with your patients, because sometimes we just don't thank our athletic trainers enough, and I think that sometimes you just need to be told that we are awesome, and I want you to continue being awesome in providing the care that you do for your patients. So I would like to thank you for allowing me to come and talk today, and at this time I will entertain any questions you may have. I think I kind of put you guys back on schedule. It was a goal to do that.
We did have a couple of questions. One of them, if you're using a metronome, how many beats per minute do you use?
That's a great question. You're going to go more off of patient feel. So I would say usually no less than 50 beats. And then on your higher end, you'll be about 180 to 200. But that's really far kind of advanced with some of your exercises.
And how many days will you do the vestibular testing? If they fail, how long will you wait to go through the process again?
Okay, so the VOMS, I'm assuming, with the vestibular test. So VOMS I usually do about a week out, depending on how the patient is progressing. If the patient hasn't really progressed in a week, I might hold off a little bit on it. But I will do that, and then I usually do it about a week later. So I don't want to over-test them. I actually want to give time to actually make changes. So during that time, I'm asking them their symptoms. I'm seeing if anything changes, but I will usually wait about a week or so before I retest them with the VOMS.
Is it imperative that they remain quiet during the card test?
No. So when you first start, you want more of a quiet, controlled environment to make sure that if there's any symptoms that are being evoked, that you kind of know what the cause is. But no, they could do the card card exercises in an environment where there's noise. So maybe you play some lighter music in your athletic training clinic. That would be okay. Or you have people in there talking. It doesn't need to be a completely silent environment.
When doing the exercises, does it make a difference if it's with a dominant hand?
No, it doesn't make a difference as to what hand the patient uses. They may feel more comfortable, especially in some of those card exercises as you move, if they're using their dominant hand because they just have better motor control, but it does not matter what hand they are using.
Okay. And should vestibular rehab be used with all concussions?
No. So what you want to do is you want to identify those individuals. So when if you do your VOMs, or if you don't have access to doing the VOMs, which is a relatively simple clinical test that you can do, then you would want to go off of their symptoms. So if I have somebody who's complaining that they have problems reading in class, they have problems in those busy environments, they have this dizziness that's going on, those are the individuals that I'm going to go ahead and do vestibular rehab on. You may have a patient who suffers a concussion. 5 days later, they have no dizziness. They're doing great. They're getting ready to do the return to play protocol. They probably don't have any deficits in the vestibular system. The majority of patients I'm seeing that are benefiting are those who kind of get to that point, plateau. They're not kind of getting any better. Things are just kind of lingering around. Other people who I've seen in my clinical practice more at risk, those who have suffered a previous concussion, usually when they've suffered a next concussion, they have more issues. Individuals who have motion sickness, okay? So if you ask your patient that question, a lot of them who have motion sickness will have some vestibular issues, so I will usually utilize the rehab with them. And then we're also seeing a little bit with patients who have ADHD, that they're kind of some of those who may benefit a little bit more.
We do have some more questions, but for the sake of time,
I'll hang around in the back.
Thank you.
Thank you very much.